Thank you all so much for having me. This is such an honor to be here, to have been invited. Thank you, Tim, for your daughter recommending me, and for Jamie vouching for me, and Eric for that amazing introduction, and for all of you for having me this early morning and being awake and ready to listen to sort of my story about leadership. And let me say happy Pride to everyone. I'll be honest, it's kind of strange for me when I first was invited to speak at a leadership conference and thinking about myself as a leader. It struck me that I've never necessarily seen myself that way. I didn't plan on being a leader. It was never part of my identity. So going way back, I was kind of a nerdy kid. You may have seen that coming. That might not be shocking. But I wasn't nerdy in the way that, like, sometimes kids are a little nerdy and they're class president. Or sometimes kids are a little nerdy, but they're also very mature and tend to always hang out somehow with, like, teachers and the principal and no adults. I was nerdy in the sense that I sort of stood apart from everyone. That was kind of how I defined myself. My grades were great. That was fine. There were no issues there. And I participated in stuff. I played sports, but I never really defined myself by any one activity. I was in choir, I did theater, but I never really thought of myself as defined by any of those activities. I had friends, I went to, parties and events, but if you would have ever asked me, what group are you in, where do you belong, where's your place, I don't know that I ever would have been able to answer that question. I always felt like, well, my place is sort of apart. I wasn't a loner. I knew people. I liked to talk to people. I had friends, but I never really thought I was part of any group. And so I certainly never saw myself as a leader in any sort of group, which is not really the recipe for, and you go on to leadership positions in the future. But what I found is that when you do perform well academically, and you generally stay out of trouble, which I pretty much did, people start talking to you about leadership pretty early on. When I was a senior in high school, I found at Marshall University in my hometown, Huntington, where I was born, raised, did all of my schooling, and continue to live and work. At Marshall, we have this amazing scholarship program called the Yeager Scholarship. And part of applying for the Yeager Scholarship program was naming all of the things you've done to show you can be a leader. That was obviously something that was very important. You're academically successful, your teachers can vouch that you're a good kid. What have you done to show leadership potential? And that was really, I remember that being a really challenging thing for me. I was in a lot of clubs and organizations and groups, but I don't know, am I a leader? Is that necessary? I feel like I have all these other skills, but it was a very challenging part of the interview process for me and the application to try to think, like, is that who I am? And if that matters to you, am I the right fit for this amazing program? One moment from my interviews that I've always talked about and thought about, and I promise is relevant, and I will say, the interviews for the Yeager Scholars Program, which is an amazing program, I will say I got it, and I am incredibly lucky. It changed my life. It was more than just a full ride to college. I was part of this group of scholars who got these incredibly intense seminars. I got extra training in public speaking, in writing. I was able to travel and study abroad. I was able to study at Oxford. So it's an amazing program. I was incredibly lucky to be a member. But the interviews, they're not like this anymore. They were terrible. They invite you for a weekend to come to the university and then sit in a room while 6 adults fire questions at you about your application and your life and who you are for as long as they see fit. This was really what they used to be like. And the point was to challenge you and push you and see how you performed under pressure. We have changed that. But I still remember one of my essays, because there were many essays in the application, I mentioned something about being a feminist. And one of the interviewers, who was a dentist, and I always remember that, this is no offense, dentists are great, this is not against dentists, but I was already sort of afraid of dentists, and this like cemented that as now I'm forever afraid of dentists. Because one of the interviewers looked at me and said, if you're such a feminist, why did you wear a skirt to this interview? Where are your pants? And I still remember thinking, like, what? First of all, that's an incredibly inappropriate question. You should never ask that in an interview. But secondly, I remember looking at this person, and this is when, in West Virginia, we would say, I got my back up. I got a little upset. And I said, well, you know, I understand that if I want to get to a position of power to change a system, I have to get into that system first. You expect me to look like this to get this scholarship. So I showed up looking the way you expected me to so that I could get into this program so that someday I can be in that position and not ask that question that you just asked me. It's amazing in retrospect that I did get this scholarship, I will say. But when, like I said, the program changed my life. I went to Marshall. I had a wonderful experience in the 8-year scholars program. I got a lot more training in those areas, which I didn't know how important that would be someday. I didn't know that all of those extra hours I spent with my speech and writing mentor, how that would play out in my life, because I didn't plan on doing any of the things I'm doing now. My goal as I went into medical school was to study infectious diseases. I wanted to be an infectious disease physician. I wanted to disappear into other parts of the world chasing viruses on my own. I had very little interest in any sort of leadership position in my home community. My plan was to disappear somewhere with no conveniences, no communication, just me and my brain and my resourcefulness hunting viruses in remote parts of the world from where I had grown up. That was what I was pursuing. But what I found in medical school as I began to be exposed to all these different parts of medicine is that I actually really love being around people. I really love talking to people, and I like everything, which is, if you're in medicine and you begin to say that, immediately people will start saying, have you thought about family medicine? If you love talking to people and you love everything, family medicine is where you belong. And I figured out pretty quickly that once I did that rotation, this is my fit. This is where I should be. I'm a family doctor. It's who I am. And I found that at my residency program at Marshall, I could do a global health track where I could still travel. I could still get extra training in tropical diseases and some of the things I was interested in, but be a family doctor, which really appealed to me. So as I started my residency in family medicine, I remember one of the first lectures, one of our professors, now my department chair, actually, Dr. Petrani, he sat us down and he said, you need to understand, as doctors in this community, you are leaders. You will be looked to as leaders, and you need to take on that responsibility and what that means in the way that you talk to people and conduct yourself and take care of people and interact. And I still remember thinking, why? I just want to take care of people and practice medicine. Like, why? I love talking to people. I love hearing their life story. I love the idea that I can help them improve their quality of life. Why does that mean that I'll be looked to sit on a board or whatever? I didn't know what leadership meant at that. What will that mean to me? But okay, that's fine. And so I worked through my residency program. I did my best. I actually did achieve a position of leadership. I was one of the chief residents my final year of residency. And I felt really good about the track that I was on at the time. I got hired at my department, which is what I wanted. I loved academics. I loved teaching. I loved talking to students and residents. And so I stayed on at my home program, became an assistant professor and an attending physician. And I will tell you that when you work in medicine, especially in the American healthcare system, which is the only thing I have familiarity with, it doesn't take long to figure out that the system that you're a part of is not working great. The hours that you spend trying to help patients access care far outnumber the hours you spend actually providing that care, which was not something that I was prepared for and was very discouraging. And what you begin to sort of account for, or at least I did in my mind, were the list of patients that I knew were being harmed by lack of access to what they needed for a variety of reasons, affordability or it didn't exist there. And the way that being a member of that system, being a part of it, an integral part of it as a physician, the way that makes you feel, nobody prepares you for. Nobody told me in medical school or residency that doing my job would sometimes make me come home feeling worse than when I got there. And my job was supposed to be helping people. And so around the time that I was starting to fear that the help that I would be able to give others would always be outpaced by the harm that the system I was working in was imposing on those patients and myself. Because I knew, we call it burnout. That's the word we use in medicine now. I knew that burnout is what other people would say I was experiencing. I would say that it was more akin to moral injury. I'm trying to do good in a system that doesn't always allow you to do so. And so you go home at the end of the day and say, did I help? My whole purpose is to help. Did I help? I don't know. I didn't know if I was doing that, which is a really hard place to be. And so at that time, as I'm starting to wonder, can I do this forever? I remember I sat down for my yearly review with one of my department administrators, a physician that I respected, looked up to, had trained me. And he said, don't worry, I know. Direct patient care, it can be very demoralizing sometimes because of the system you're working in, but there's a way out. We have you on a track to be an administrator, which means you don't have to take care of people as much. That means that you can do a lot more of what I do and a lot less of the actual doctoring. And, we've already sort of planned, you're one of the younger members of our department, so it's going to be a couple decades, but don't worry. We have you on this track. You'll get tenured, and someday you could be department chair. You never know. You're that. We see that potential in you. That is, again, that leadership. We see that in you. We know you have that, and here's what it looks like. Here's the ladder. And I remember, well, first of all, that's incredibly flattering. Yes, obviously, I felt very honored that I was seen that way. Who wouldn't? But then I thought, I don't want to do that. I have no interest in that job. No offense to anyone who does, but that was never what I wanted to do. I love taking care of people. I love the hands-on, face-to-face work of getting to know someone, understanding what they need and what they're trying to accomplish, and then figuring out how I can help them get there. That is what I wanted to do, and I had ended up on this track to not do that anymore. But at the same time, the work I was doing was also not bringing me joy. And I felt very stuck. At that time, I was an assistant professor in the department. I did 12 weeks a year, so every month I would do a week of 24-hour call for 7 days where I was on at the hospital. The weeks that I wasn't doing that, I was working like 50 to 60 hours in doing clinical work, taking care of patients, lecturing to students, all of the other responsibilities of the department. Sometimes they would send us to other facilities, like rounding at the local psychiatric hospital. So doing lots of work, constantly busy, trying to keep up with writing notes, the electronic medical record, which if you know a doctor, we'll all complain about it. I had 2 children at that point that I missed all the time, that I was constantly feeling pulled to get home to, but then get my work done and then get back to work and not rush the patient in front of me, but also, I was also breastfeeding at the time, so also like, I need to get home and feed my kid right now, or I need to pump right now. All of that I was trying to balance, and in the midst of all this, my husband and I had started this little podcast back in 2013. We had started a medical history podcast mainly because I like medical history. I'm nerdy. I had always had an interest. They don't teach you that really in medical school. You'll get little snippets here and there, but that's not like part of it. You don't get the how did we get here story very often. So I wanted to find that out. So I would read about it, and then I would tell Justin these funny stories, and we thought this might make an interesting podcast. Our goal was really like, this will make someone laugh and maybe win a round of pub trivia. That was really what we set out to do with the podcast. I had no expectation that so many people would listen to it. I had no expectation that we would write a book based on our show, which is, what we were able to do. I had no expectation that we would tour our podcast live all over the country and do live shows. So I had, at the same time, all these opportunities in this whole other world that were arising as I was looking to like my life's work, my career, what I'd wanted to do since I was 12, and not finding satisfaction. In that moment, I didn't know what to do. I was completely overwhelmed. So what I did is I went to my department chair and I quit. I walked in and said, Dr. Petrani, I love this department. I love the people I work with. I love my patients. I love students. I'm going to quit, though. I am so lucky that he is my department chair because he didn't let me just quit. But that was really, I didn't know what else to do. I thought I just have to, like, get out, regroup, figure it out. I don't know what comes next. I don't want to stop practicing medicine, but I don't know how to do it in this system, and I don't know what my other alternatives are. Luckily, he's a wonderful person, and he said, sit down, calm down, drink some water, let's talk. Surely there is something. We don't want to lose you. We think that you are a benefit to our department. That's fine. You don't want to work as many hours. You want more freedom to do other things. You want to be home more. You don't want to be an administrator in the future. I got it. What can we work out? Which was, I can't thank him for the rest of my life. I will thank him for that. Because what I was able to do is pull myself away from the office a lot more, which allowed me to be home. That was great. I could see my kids again. I was still connected to the program. I still do, to this day, I do inpatient service. So actually next week I'll be on at the hospital. I have a team of residents and students, and I take care of people in the hospital. But I have a lot more free time and flexibility so that I can do other things. And this is really where the path that I was supposed to be on started to show itself. You may know this, but Huntington, West Virginia, where I live and work, has been notorious for being one of the sort of epicenters of the opioid crisis. It is an unfortunate claim to fame that Huntington has, but there are many articles and stories that have been written. There was a documentary about it, and as in a lot of places, first it was the prescription drugs. Once the pills went away, heroin came in, and now we have a major problem in Huntington with IV drug use, and inevitably, when you have a rise in the use of IV drugs, you have HIV that follows. That is where Huntington is today. And we're still in the middle of an uncontrolled outbreak, even as I speak. Part of mitigating the spread of any sort of bloodborne pathogen is harm reduction. And if you're not familiar with the concept of harm reduction, if you wore a seatbelt on your way here, you practiced harm reduction. The safest thing to do, because automobile accidents are a major cause of mortality, the safest thing to do for all of us would be to never ride in a car. That seems impractical. So we wear our seatbelts as a way of reducing any harm that might come to us in the car. Harm reduction, when we apply it to things like HIV or hepatitis, it means we accept that people are going to use drugs. We would like to reduce the harm that comes to them while they are using drugs. And the ultimate goal in harm reduction programs is we would like to help you, when you're ready, get into recovery. That is always the end goal if we can get there. And I will tell you that this is a very controversial topic in many places, especially in Huntington, because harm reduction programs also involve handing out clean syringes and taking back the used syringes. And that piece of it, it really upsets a lot of people. And I can tell you, I have stacks, because I've had to collect them in the work I do now, of evidence for why this works, why this is evidence-based medicine, why this is good. And at the end of the day, we'll do a lot more good than harm. But science doesn't always change everyone's minds. I think we all know that. So there was a town hall held back in 2019 at a local church in Huntington. And the aim of this was to sort of generate enough public outcry against the harm reduction program to try to force city leaders to shut it down. That was the goal. So I went with my evidence and my speech prepared so that I could speak up and say, I understand why it triggers this emotional response, but this is medicine. Here's why it's necessary. That was not necessary because I was in the majority at that meeting. I was pleasantly surprised. Many people spoke about how the harm reduction program helped them get into recovery. It was a great success for those of us who really wanted to see that program survive. But while I was there, one of the panelists at the town hall Amanda Coleman is the director of Harmony House in our community, which is a day shelter for people experiencing homelessness. And I was so impressed with the way she spoke about it. I went up to her afterwards and I said, hey, at Harmony House, do you have like medical services? And she said, well, we used to, but the person who used to come stopped coming, and we don't have anybody. We have a little clinic, but we don't have, a doctor or a nurse practitioner or anybody to see patients. And I said, would you like me to come and just do volunteer medical care a couple days a week? Would that be something that would be helpful? I have learned since that when you ask somebody who works in services for people experiencing homelessness or at a nonprofit, can I come and do free work for you? The answer is yes. Usually accompanied by tears. Yes, please come. And I'm so lucky that I went to that town hall and that I met Amanda, because from that day forward, I've been going to Harmony House at least 2 days a week. And when I first went, I had no idea what I was walking into. I was used to working in the system of medicine. I was used to having a front desk staff that signed people in, having a nurse that I worked with that took people's vitals and a little bit of their history and refilled their medications. I was used to having an electronic medical record, which for all of its problems was really easy for me to refill things, order labs, print things out. There's the lab, there's the x-ray place, take your thing over there. All of it was so easy. None of that existed at Harmony House. It was just me. And so very quickly, I had to figure out, we don't teach doctors this anymore, how to call in a prescription on the phone. I didn't know how to do that. I remember the first time I called the local pharmacist, and I got him on the phone, and I was like, hi, Matt? Okay, Matt. Matt and I are great friends now. Matt, my name's Sydney. I'm a doctor. I'm working at Harmony House. I don't know how to call in a prescription. Help me. Which has been great, because I've learned so much from talking to a pharmacist multiple times a day for years now. But I also had to get a prescription pad. That's another thing they don't teach you in medical school anymore, how to write a prescription. Nobody knows how to do that. It's all on the computer. I had to learn. I had to Google, how do you write a prescription? We don't know that stuff anymore. So I started to try to figure out, we had a little med room. That's what I was told. Here's your med room. Utilize whatever you want in this med room. So I walk in, and my med room at the time was like a shelf full of, I think I had some Band-Aids and some alcohol swabs, which were still good. But for the most part, it was full of expired laxatives that someone had donated a lot of. And then a lot of herbal medicines and supplements and vitamins, a lot of homeopathic remedies. It was a very strange collection. And so I called Amanda after my first day and I said, okay, are you okay with me getting rid of some of the things in this med room that no one can use? And just, I don't even mind, I'll donate it. I'll just buying a few basic things. I would like to have Tylenol. We need some antibiotic ointment, just basic things. I think I can get my department to give me a few little equipment things if I need to, I won't get gross. If there's an abscess that I need to take care of. Those sorts of things, I think I can get some of that donated, and then I'll pay for some other things. Is that okay? And Amanda said, hey, you're in charge down there. Just go for it. Which was totally shocking and overwhelming. I thought, I'm in charge? I can just do whatever I want here. I can shape this the way I want to. And I will tell you, working outside the medical system to provide medical care, oh my gosh, there is no guidebook for that. Nobody can tell you exactly how to do that, because so much of the system is tied to billing. And what I was doing was volunteer, so I wasn't charging patients. In order to get a prescription covered, or order a lab, or get a piece of medical equipment like a walker or something, all of that is tied to billing. And I wasn't billing. And I had no idea, how do I get any of these things for patients? I don't know how to do any of this. And none of the people who trained me knew either, because they had all worked in the same system that I had worked in. And so it is very difficult to try to figure out that path in our current system. A cynical person may suggest that this is intentional. I'm not cynical, but it is very difficult. So with nobody to tell me what I needed to do, I just decided I'm going to let the needs of the people that are coming to see me dictate what I do next. the thing, this is going to take a while. I'm going to have to build this based on the needs that are presented to me. What are people asking me for? What problems are they bringing to me? And then I will respond to that by filling my shelves and my medication room. I'll figure it out from there. So I started to talk to the patients that I was seeing, which took a while, let me tell you. The medical field in general, we have alienated certain groups of patients, especially people experiencing homelessness and people who use drugs. Their experiences in hospitals and in doctors' offices have been so negative that it took me a while to get people to just see me, to talk to me. Walking through the front office and into the clinic was too far. That was too far of a bridge for most of my patients at first. So what I did is go out to the sidewalk with my bag and sit on the sidewalk out front and talk to people. Or sit in the day room where people can hang out and have some coffee and rest if they've been outside all night, and just sit and talk to people. And it was a while before I actually had people signing my little sign-in sheet and coming back to talk to me, because I had to prove to them I am meeting you where you are, not just physically, but where you are in your journey, in your recovery or not right now. Whatever it is, I'm there with you. What do you need? Eventually, I was able to get people, and I have proven that I'm there to do good and not harm, but it took a long time. I also had to reach out to a lot of people, just start making phone calls to social workers. Hey, how do you make this happen in the hospital? Because you do it and I don't know. I called pharmacists constantly. I had people come to see me who had serious mental illness that, honestly, in family medicine, we usually refer to psychiatry for, but these patients were not going to go see a psychiatrist. So it was me. So I called my friend who's a psychiatrist and said, help me. I need to manage schizophrenia on my own. Walk me through, they're on this medication. What adjustments can we make? I called surgeons to figure out, I have a patient with an ostomy. I don't know how to manage or get supplies for this. How do you do that in your office? Whatever I needed to do to navigate an issue, I figured it out, or I called somebody, and we worked through it together based on the need that had arisen in front of me. And when it was too big, then I had to get people into the hospital. And that was one of the hardest things. It still remains one of the hardest things I do, which is when I have someone who comes in that is clearly septic, maybe going into shock, to convince them to go to the hospital in that moment is so difficult, because they've been to the hospital. They know what that's like. They don't want to go back. And what I found is that because I still have that tie, because I still work at the hospital, because I still know people in the emergency room, I still know the teams of doctors who admit patients, because I'm still part of that system, I have been able to, having that connection has really facilitated. I will call, I will talk to people there, I will advocate for you. And if you have a negative experience, if someone treats you in a way that they shouldn't, I'll get them in trouble. So there will be accountability, and that really helped to facilitate getting people to agree to go to the hospital, because they knew, and people at the hospital know, if you're mean to patients, Dr. McElroy will find out, and Dr. McElroy will go tell on you. And so I found a way to help troubleshoot that problem as well. Again, based on what is the problem, you're the one with the need, you tell me what the problem is, and how can I respond to it? How can I address that? Another need that arose at that time is in Huntington. This is an interesting fact about West Virginia. West Virginia has the highest percentage of teenagers who identify as transgender in the country, which is always a statistic that shocks people in West Virginia. Practicing in Huntington, I could have told you that that was true. And in Huntington, I realized a few years ago that we only had one doctor, and we have so many Huntington has several, 2 major hospitals and several major medical systems and a medical school. We're just awash with doctors. We had one doctor who was prescribing hormones for gender-affirming therapy for adults. Nobody was taking care of children, but only one doctor for any transgender adults in our community. And I remember thinking, that is ridiculous. So I had a patient who had asked me one day when I was working at Harmony House, do you know anybody who can do this? So I knew this one doctor, so I called him, and he was like, oh my gosh, This poor guy, he's trying to retire, and he won't because he's the only doctor who does this in the community, and he does this like 1/2 day a week. And I'm like, Dr. Driscoll, can you get this patient in? And he says, I don't know how to get any more patients in. I'm totally overwhelmed. And I said, can you teach me to do what you do? And he said, it's not hard. Family doctors should be doing it already. Yes. So we sat down. He walked me through it. I figured out I can do this care too. And I started taking care of patients myself because there was a need in the community. Nobody was filling it. And so that must mean it's my job. I found it. I found the need first. I should start doing it. Now, over the last 3 years, a lot has changed, obviously, in a million different ways. During COVID, providing all these services at Harmony House became incredibly difficult. People who were involved in services for those experiencing homelessness all over the country can attest to this. This was our first question. If you have someone who is either sleeping outside or somebody who's staying at, let's say, the city mission, and they either test positive for COVID or they've been exposed to COVID, where do you quarantine that person? You can't tell them to go home and quarantine. They don't have a home to go to. And we immediately realized this is going to be a problem. And with my patient population that I take care of, they're incredibly medically vulnerable. So we all knew the danger of what, COVID unchecked could do among our population. So we set up in Huntington, and I think a lot of places did this, a non-congregate shelter, what we call the isolation and quarantine shelter. In practice, it's the Econo Lodge on Route 60. That is what it is. But we were able to use FEMA money to take over half of the Econo Lodge and house people there temporarily if they had COVID or had been exposed to COVID and needed to quarantine. But what that necessitated was like somebody to be on call in case there was some sort of medical emergency or to help manage. Like a lot of these patients did continue to have substance use disorder, serious mental illness, other issues. So I became the 24/7 on-call doc for the Econo Lodge and had to figure out things like, I remember one of the first calls I got was, we have a patient here who's quarantined. They drink, they have alcoholism, they drink regularly. They don't want to stop. And you can't just have someone who drinks a lot of alcohol every day just stop drinking. They will withdraw, and that can be fatal. But this also isn't a medical facility, so I can't do like the detox protocol we would do in a hospital because there's nobody there to monitor it. So what we do in that situation, and we do this in the hospital, this isn't that wild, what we do is we give people beer. We write prescription beer. It's just beer. Actually, at our hospital, I believe it's Bud Light. But that is what we do. And so I had to figure out, okay, we've got to have a beer protocol at the isolation and quarantine shelter. Because otherwise, either people are going to go into withdrawal, and that can be fatal, or they're going to leave. And we don't want that because they have COVID. We want them to be somewhere warm and safe where they're getting food and plenty of fluids, and then they can be checked on. We don't want them to leave. So I remember that people calling me and saying in the middle of the night, can we start your beer protocol, doctor? And I remember thinking, if my mark on medicine, if the McElroy protocol is how many beers you can safely give someone, I'm going to be so disappointed that that's the mark I left. But, we had to figure these things out. I still do this. I gave my phone number to everybody. To this day, I will randomly get like a picture of an abscess on my phone from someone, and I'm like, okay, back up. Who is this? I need your name. How long has this been there? Can you call me? But it became necessary during COVID to adapt. People needed to contact doctors. They couldn't come see me. This is how we did it. And as I helped navigate all that, I became a lot more skilled in all these areas, right? Because I had to. I got better at wound care. I got better at harm reduction. I got better at counseling and caring for people with substance use disorder and serious mental illness. And I learned about things like it is so hard. The process of getting somebody like a voucher for housing is an incredibly difficult process. One of the steps is to get a doctor to sign a form if you have a certain diagnosis, like substance use disorder, mental illness, or HIV. That's all it is. It's you check a box and I put my signature on it. It was taking a couple months to get these forms done for our clients because you had to make an appointment. None of our patients had established with a doctor. It takes about 2 months to get in with a doctor. And sometimes they would say, I need to have you come back before I'll sign my name on this form. So I'm right there. So here I'm able to shave 2 months off of the process of getting somebody housing by putting my signature on a piece of paper and just confirming that, yes, the diagnosis I know you have, you do have. It's amazing how when you work in these systems, like, you start to learn these things. And what I found is that when you do good things, people notice. So after a while, was asked to serve on the Harmony House Board of Directors and then on the executive committee. And of course I agreed because I knew I could do something. I knew that this would help. Like, I am there hands-on with our patients every day. I know what their needs are. I can add something to this conversation. Yes, I will happily be on this board. Because I worked with harm reduction so much at Harmony House, I cannot hand out syringes. I do not do that. But I can do a lot of other things with harm reduction, talk to people about safe injection practices, hand out naloxone. I hand out lots and lots of naloxone, which is the overdose reversal medication, which anybody can be trained on. This is my little pitch, that anybody can be trained to administer naloxone. It's a nasal spray. You almost wouldn't need the training. It's so, you can just look at it and you understand how it works. But you can save a life that way. So I was already doing a lot of harm reduction, and so I was asked to serve on the Harm Reduction Advisory Board for our local program. And I said, yeah, absolutely. I would love to be a part of those conversations because I'm seeing the people that you're serving, and I can probably give you useful information about, you know, how to improve this program. As I became more active in the community, the scholarship program, the Yeager Scholars, reached out to me and said, hey, do you want to be on our board? That would be great if you'd come be on the Yeager Scholars board. And I thought, oh, I would love that. I would love to be a part of that program that meant so much to me. And I found myself interviewing people for the Yeager Scholars program, sitting in on it is not nearly as terrifying as it used to be, finalist weekend, to interview people who used to be in my position and ask them reasonable questions. And now we give everybody free Marshall t-shirts for their interviews. So you wear a Marshall t-shirt and whatever the heck you want on the bottom. Please do wear something on the bottom. And that's fine. No suits or skirts or pants questions anymore. We have found that it has been a great leveler for that part of it because not all of our students can afford to wear a suit to their interviews. So how about we just put everybody in a Marshall t-shirt and then we can talk about the things you've done. The city was also appreciative of the work that I was doing, and the mayor reached out to me, this has been just in the last couple months, and said, hey, we would love to have you come advise us on public health and drug control policy. We're putting a team together, you know, during COVID, like a lot of things got put on the back burner. The opioid crisis, unfortunately, was one of them. And all those years that we worked to watch overdoses go down and more people go into recovery, we've lost a lot of that ground. And we're trying to make it back up. Do you want to be part of our team? Yeah, absolutely. These are the people that I care about. I know what they need. Yes, I would love to be part of that conversation. And then, again, because HIV has followed that, and we're seeing the number of cases in our community rise at an alarming rate, I started to realize we need to do more for that. This is I will say this is a very West Virginia mindset. There is no expectation somebody is coming to save you. You have to figure it out for yourself. So at Harmony House, we all got trained in doing rapid HIV testing ourselves. That's not something that we're generally taught as doctors in medical school. I studied how to do HIV pre-exposure prophylaxis, a medication you can take every day to decrease your risk of getting HIV. And how can I do that in this patient population, especially people who use drugs? This hasn't been studied nearly as much because it's a really difficult patient population to remain compliant on a medication. So I started working on that. You know, we can do this, I can study this. Hey, that's always a great pitch to the university. Help me get some free meds and I will study this for you and you can publish this. They love when you're going to publish something. How can we educate people better? How can we link people to care? So I've diagnosed you. How can I ensure that I get you somewhere where you can see a doctor, get your labs, and get on this, you know, life-saving medication? How can we do that with people who are experiencing homelessness and still in active addiction? And as other medical organizations have started to see the work we're doing, they've started to team up with us and get back on board. We've tried to reinvigorate the health department to start addressing these issues as well as they were prior to COVID. All of this stuff
has started to happen because we have been making all this noise about it. To the extent that we actually tomorrow have a big, in Huntington, one of our big Pride events is taking place. And I am tabling there, providing HIV education, information on how to get free PrEP if you're uninsured. Here's how to access medications for free, and doing HIV testing live at the event if people are interested in that to know their status. I am still a member of the family medicine department, as I said. I really do love teaching, and so I didn't want to lose that. And I was contacted just last week by hospital administrators who said, hey, you know, we're really starting to think, we're really beginning to think that social determinants of health might be important. Good, okay. The important thing is we got there. It doesn't matter when. The important thing is we got there. And we know that the work you do makes you kind of uniquely positioned to understand how we could better address the community. Not just what's happening in the walls of our hospital, but what is happening to people before they come in and after they leave. We think you might be able to help us in understanding how to do that better. And we'd like you to be the physician director of this new division we're creating about social determinants of health. Is that something that we could get you to do? And I was a little reluctant because I've been pushing myself away from the system for so long, but then I thought, I could actually maybe start to change it. Maybe from everything I've learned and done, I could start to make things in that system that I was in originally that I found so harmful. Maybe I could start to make it a little better with the experiences I have and with the voice that I found. So I agreed to do that. I don't know what it is. I haven't even had a meeting yet, but I just got that call. And again, with all this, I won't get political, but when you start doing these things, eventually, especially in West Virginia, people will start calling you from the city, from the county, from the state, from the Capitol, and say, do you want to run for office? And at first my answer was, no, I don't think so. Thank you, though. But eventually, what you start to realize is that if you're really dedicated to meeting the needs of the people you serve, maybe that is the next step. Maybe that is what you need to do. And if no one else is doing something, if you're looking around waiting for somebody else to do it, maybe that's because you're the one who's supposed to do it. And so I'm running for office, which I would not have predicted a few years ago. Leadership sort of found me. It was not something that I necessarily sought out, but I have arrived in that position. And again, it's weird to put that, I don't think of myself that way, but objectively, I have found myself in multiple leadership positions. I knew that climbing that ladder that was sort of presented to me, I knew pretty quickly like that I don't see myself on any of those rungs. I don't know how that suits me. But instead, what I started doing was kind of forging my own path. That way doesn't work. I'm going to head out that way and sort of like chop my way through the bushes and figure out what that looks like instead. And what happens when you do that, if you're doing a good job, is that other people will start to follow you. Is that at some point you'll turn around and realize you're not alone on this trail you thought you were blazing. There are other people there with you, and maybe you're leading them and you didn't even realize you were doing it. Now at Harmony House, it's rare that I'm alone. Because I've been working there for a while, we have now created like a rotation for students. I have medical students, I have undergrad students, I have pharmacy students, I have nursing students. They all want to come work at Harmony House, which is great because I can take care of a lot more people. And I am helping my patients see, look, there are a lot of people in the medical profession who care about you. There are a lot more good people than you are seeing, I promise you, because all these people are coming to where you are to learn how to take care of you. One of my oldest friends, my former co-chief resident, Dr. Mays, she decided at one point, because as I was taking care of people who were experiencing homelessness, a lot of people would get housed and then still want to come see me, which really isn't the model we've set up. It's great, but at that point, we really need to get them hooked in with a primary care physician who can do all the stuff I can't do. Like, I'm not doing preventive care, I'm not scheduling colonoscopies, I'm not doing pap smears, all those things that I'm just not set up to do, but patients need. let's get you in with a doctor who can do that. And what Adrian said was, why don't I start doing home visits in some of the apartment complexes that you house a lot of people in? Because we have certain complexes where a lot of our clients get housed. I'll come and start doing these primary care events where I'll come to them and bring a bunch of students and bring immunizations and bring somebody to do labs. And we'll come to them and start taking care of them. So now our department does that outreach to people after they've been housed to help hook them into care and meet them where they are. In Huntington, we also have our former fire chief, Jan Rader, is kind of a celebrity. She was in the documentary Heroine, which was featured Huntington prominently, and it was nominated for an Oscar, so she's been to the Oscars. She was in Time magazine. She's very cool. She is the mayor's director of drug control policy, and through our advisory council meeting, she came up to me and said, you know, I'm an RN too. Could I come work with you at Harmony House? And I said, yes, absolutely, you can come work with me. So now, once a week, I have an RN with me who can do lab work right there. So I can order blood work on my patients right there in Harmony House. And Jan is also just a great all-around troubleshooter. But so now I can do labs there. So all of that, I started doing it, and other people were drawn to come do that with me. So where does that leave me in terms of leadership? Well, I was working in a system that I felt needed a complete overhaul. And instead of what I was asking myself in my practice, what will the system let me do for my patients? I changed the question to, what do people need, and what do I have to do? What do I have to change to make that happen for them? Let's start with the need and work from there. And this required a lot of independent thinking and a lot of confidence, which I wouldn't say I necessarily have a ton of, but I'm learning. And this has made me more effective to become a leader in this way. I feel very confident when I talk about what my patients need. I know what my community needs because I'm a part of it every single day. I'm out there. I know what these needs are. I did it from the bottom up. I did it by myself for a while. And as my goals, have never changed, I've been able to draw more people to come do these things with me and help me. But I think the key is that I never compromise that point. I am basing everything I do off the needs of the people I serve. And it can be challenging when your rewards aren't clear-cut. I don't get paid for the work I do, and that's really hard when I'm incredibly lucky and privileged that our side gig, our podcast, helps us pay the bills, so I can do all of this work. So I understand I have that privilege. Not everyone does. But it's also, you get home at the end of the day, you don't have like a paycheck. You can't go like treat yourself to a nice dinner. It starts to get hard in our system to see like the reward for the good you did, or to feel like you succeeded. Now, even if you don't need a reward, just to know you did your job. It's hard because our system is structured that you get a paycheck. That's how you know you did your job. With this work, each accomplishment is just building on the last one and providing a foundation for the next one. And so the rewards aren't always as obvious, but what I know is that every act of compassion, every act of kindness, every act of service makes a noise. And each of those acts is just a whisper of the change that will come. But when enough of them are sort of stacked on top of each other, they make enough noise that people start to notice. And when there's a cacophony, a lot of people will notice, and they will follow you. And then you're going to be leading. So you can never lose sight of where you're going and why you're doing the things you do, because now you got people behind you in your wake. So thank you so much. This was an incredible honor to get to come speak with you, and I guess we're going to have a conversation soon, so I won't ask for questions. I don't know. Am I supposed to ask for? Okay. Thank you.